Hello everyone, again from the laboratory of Sakbao Dr. Sterev Hospital. Now I'm presenting Michel De Vos, who is Senior Medical Director at the Center for Reproductive Medicine at the University of Brussels. His current research activities are focused on reproductive endocrinology, polycystic ovary syndrome, in vitro maturation of oocyte, and fertility preservation. He is a coordinator of the Photo Freezing Ovarian Tissue and Oocyte Consortium, encompassing oncofertility. He also he has a lot of research projects in several universities in Brussels, and also over 110 scientific articles co-authored and authored. So I give you the floor now, Professor De Vos.
Thank you so much for this kind introduction. It's great to be in Bulgaria again, and thank you, Professor Chef, for inviting me to give this presentation on fertility preservation. It's been a while. I was in Borovets in 2011, and now it's 2020, and obviously many developments have taken place, specifically in the area of fertility preservation. It's becoming a hot topic for fertility specialists. And on this slide, I present to you my disclosures.
Professor De Vos, could you share your presentation again, because we see you?
You cannot see my presentation. Can you see it now?
Yeah, now it's starting.
Now it's starting. So you did not?
Yeah, now. Thank you very much.
Okay, thank you. So everyone is seeing this first slide, and the second slide presents my disclosures. And on this slide, you see that from the 70s, like 40 years ago, until now, there has been a huge advancement and progress in the survival of cancer, of all types of cancer, which means that men and women who get cancer, they will be cured from the disease in many more cases. And we see that actually these days, up to 1% of young women are survivors of cancer. And these women, obviously, they have a good life expectancy, and they should also expect quality of life. And fertility and reproduction are very important components of quality of life. Now, this is not the presentation that I wanted to show you. What's going on here? I tried to share my presentation. I'm sorry about this. Can you see this slide?
Yeah, it's opening. Yeah, now we see it from the beginning.
I'm sorry. Yeah. Okay. So basically, we know that the survival rates have increased tremendously, although the risks to become infertile are still quite important. And women who have breast cancer are those who have the highest risk of infertility, and they have up to 70% lower chance of pregnancy compared to the general population. So we see a dramatic reduction in reproduction. And basically, this all comes back to physiology, when we know that when we are born as a woman, we have about 1 million oocytes in the ovary. And then with age, the number drops and the quality goes down. But if someone at a very young age is having a cancer diagnosis and needs chemotherapy or radiation therapy in the pelvis, there is a dramatic loss of follicles. And then after recovering, there could be a still like loss of ovarian function for a couple of years. At a certain time at a certain point in time, the patient will become will have menopause at a very premature age. And now I would like to show you on this slide how this works, how chemotherapy affects the ovarian function. Basically, you have to bear in mind that many women, when they have the diagnosis of cancer, can have either a high ovarian reserve, a median ovarian reserve, or a low ovarian reserve. And it's basically those women with a low ovarian reserve who have the highest risk of not having any recovery after cancer when the chemotherapy is done. And it's for those women in particular that fertility preservation needs to be considered. If you have a high ovarian reserve at a young age and you have cancer, then there is a good chance that after the drop of anti-Mullerian hormone levels, you will have a recovery of these levels, and that after all, the fertility will not be that impacted. Nevertheless, AMH, anti-Mullerian hormone, after chemotherapy is a weak predictor of short-term fertility. It's a good predictor of age of menopause, but not of fertility. Even women after cancer with low AMH levels can still get pregnant. So we're really doing this fertility preservation for those women who do not have a recovery of their fertility. And it's very difficult to predict. This is a slide from a study in France in 250 women with breast cancer, where it was shown that after chemotherapy, 60% of these women had undetectable levels of anti-Mullerian hormone. So it's a very important issue, certainly in breast cancer patients, as I told you before. Now, another way of looking at prediction of amenorrhea in breast cancer patients is to look at age and anti-Mullerian hormone levels and try to combine these parameters in order to predict the risk of premature menopause. So it turns out that if you have an age of 38 when you have the diagnosis of cancer, like above 38, there is a very high chance that you will not have recovery of menstruation after chemotherapy. And also, if you have an anti-Mullerian level, anti-Mullerian hormone level of less than 3.8 picomoles, which corresponds to more or less 0.5 nanograms per ml before chemotherapy, then again, there's also a very high chance that you will not have recovery of ovarian function. So we use these parameters to decide whether there is a high risk to have ovarian insufficiency or not. Now, the way gonadotoxicity works is as follows. So we have a category of high-risk chemotherapeutics, including those alkylating ones, cyclophosphamide, for instance, where it was found that there are several pathways of ovarian impact. First of all, there is the apoptosis of the follicles, but also the follicle activation. So many follicles are just lost as a result of chemotherapy because they become activated. Fibrosis of the tissue is also a parameter. So it was found in a recent study in Monash in Australia that basically the small follicles, primordial follicles, primary follicles, they are usually affected in their oocytes, whereas the larger follicles, the antral follicles, the secondary, the oocyte can still survive, but it's the somatic compartment there that suffers most. So this was a really interesting study that gives us an idea about the mechanism. Now, several guidelines have been developed to tell us what to do in which case. And basically, the majority of these guidelines are based on several assumptions. So first of all, we have to focus on quality of life. We have to counsel at the right time, at staging. So really, you have to make sure that you do not lose any time. You have to refer the patient early to the fertility clinic before the start of cancer therapy, and you have to follow up the reproductive markers. So you can find different guidelines. The most recent one is the guideline issued by ESHRE, European Society, which is now available online. Now, this is a study that we performed, a retrospective study in women who had breast cancer and who had fertility preservation before start of chemotherapy. And it was found in these cases that there was no delay between the diagnosis of cancer and the start of the chemotherapy as compared to women with breast cancer who did not have fertility preservation. So you can reassure the oncologists and the patients that if you use the time in the most efficient way, that you do not really delay the start of chemotherapy. So this is an important message for oncologists. Now on this slide, this is a picture from Teresa Woodruff's original paper about oncofertility. 2009 was actually the year when the term oncofertility was developed by Teresa Woodruff. And you can look at the options in many ways. In girls and women, you can either stimulate the ovaries in order to get oocytes, and mature oocytes can be vitrified. And this is an established approach. There is an innovative approach in that you can also obtain immature oocytes. You can vitrify the oocytes after in vitro maturation, which is not considered as a routine procedure, but it's an innovative procedure. So there are a couple of children born after IVM in the setting of fertility preservation when there is no time for stimulation, when you do not have the 2 weeks that you need to have ovarian stimulation. Same here with ovarian tissue freezing. It is now considered an established technique, so cryopreservation of cortex of an ovary when there is no time to stimulate the ovaries can be done, and this is considered routine these days, and you can transplant the cortex later on. You can also, on top of that, and this is what we do nowadays, when you remove part of the ovary, you can also identify immature oocyte cumulus complexes in the culture dish when you are cutting the ovary, and you can mature these oocytes, and this is also considered experimental. So same here, I'm not going through this with you again, but a very recent flow chart for what to offer to your patient who is diagnosed with cancer, depending on whether she's a woman or a man, and whether you have at least 2 weeks available to stimulate the ovaries or not. And so you can all read this in the European Society for Medical Oncology Open Journal. This is a more or less complicated slide that I'm not going to spend too much on, but when we have the option for fertility preservation in our patients, we have less than two weeks available, then we can offer all options of techniques. So you can also combine ovarian tissue cryopreservation with, as I said, in vitro maturation of oocytes. You can also perform an egg collection to obtain immature oocytes in combination with the removal of tissue from the other ovary. So the combination is a feasible method. Whether this really increases the chances of a baby for a woman is certainly not known at the moment. Breast cancer patients are the majority of women in our center who request fertility preservation. We also have women with leukemia, lymphoma, and some women with cervical cancer. These are the majority of women. And as we published recently in Human Reproduction, in the majority of cases, we still have time to perform ovarian stimulation, even in breast cancer patients who need to start neoadjuvant chemotherapy. Usually the oncologists, they know that in 2 weeks' time, we can stimulate the ovaries, we can obtain mature eggs, and then they can start the chemotherapy. 2 weeks, that's all we need. And the majority of oncologists, they accept this. We also did some women where we did 2 stimulation cycles, but this is only in very exceptional cases when there is a lot of time available before the start of the chemotherapy. We sometimes perform egg collections for IVM when the patient has polycystic ovaries, for instance, and when there is no time to stimulate. we remove tissue of the cortex, and in the large majority of cases, we also combine this with IVM of oocytes from the tissue. So different possibilities. Now, the standards of quality may vary from center to center. So it's really important to spread the message that fertility preservation should ideally not be performed in all fertility centers, because it really requires a certain level of expertise, lots of questions: who should be paying for this? Should it be the patient? Should there be some kind of funding from the government, from the public, for this situation? Ethical reflections also: is it really needed to do all this effort for a woman with cancer to give her the option of having genetically owned children? The other option is, of course, to do egg donation in these women. So that's a very important reflection that we should make. Also, it's difficult to predict ovarian function after cancer treatment. In the long term, we never know what to tell to these patients in terms of age of menopause. Very difficult to say. And also, young girls, at the moment, there is very little information available on the reproductive potential of young girls with cancer who had ovarian tissue cryopreserved, because these girls, we still need to wait until they come back to use this tissue before we can really say something about the potential. Now, if we look at the success rates of oocyte cryopreservation in cancer patients, this slide shows it all up. It's from Ana Cobo in Spain, and she already presented a very favorable results. If you use 7.5 eggs, 7.5 eggs on average from a woman with cancer, and you use these eggs, then you obtain a 35% chance of a live birth. And this is very similar to the situation where women have their eggs frozen for non-medical reasons, and this is social freezing. So there is no difference in the success rates of vitrification of oocytes from cancer patients compared to women who want to have social freezing. So who are the women who come back to use their eggs, to ask for fertility treatment? Now, we did a study in 207 women who had cryopreservation of oocytes or ovarian tissue between 2012 and 2018, and only 31 of them came back to use, came back to the clinic because they wanted to have a baby, and their oncologist told them, well, now you're cured from cancer, you're in remission, you can start to try for a baby. Now, and in some cases, patients, they try for a couple of months just to become pregnant naturally. But if that doesn't work, they come to the fertility clinic. Obviously, you see also these types of patients. And in more than one third of all these patients, what we did, we checked the ovarian function, and when the ovarian function was still acceptable and was still okay to perform IVF with fresh eggs, this is what we did. So we did in 12 of these women, so more than one third of these women, we did IVF, and in these women we found that 9 out of 12 had a live birth after IVF. Now, sometimes you have to use modified natural cycle IVF if the ovarian function is really, really low. So we are talking about very young women who have a very low ovarian reserve, where ovarian stimulation does not really work. And in these women, we have the option to use natural cycle IVF. Now, some women did not have ovarian function preserved, and they were amenorrheic, so they had premature menopause. And in these women, we saw that also almost 50% had a live birth when they used the frozen oocytes or the frozen embryos. So this is very reassuring news for women who have fertility preservation. Ovarian tissue transplantation. Now, this is the figure from 2018. the moment we have 3 live births in 6 women who had ovarian transplantation. So this is also becoming promising. Now, just to show you that from the pregnant women, the 8 women who had a live birth after the use of frozen tissue, the majority, as you can see here on this slide, the majority of these women had breast cancer, and when they returned, they had so those who got pregnant, the majority had very, very low anti-Mullerian hormone levels when they came back. So the idea is to check the ovarian reserve after cancer. If you still have some degree of ovarian function, then there is no need to thaw or to warm the frozen material, but you can still try to get pregnant with IVF with fresh eggs. Now, this again, 10 eggs give you approximately a chance of 40% of a live birth, and this is the same situation in the setting of social freezing. So this is obviously very dependent on the age of a woman when she gets cancer. Now, pregnancy after breast cancer, that's a very important topic. Is it safe or not? Well, there is an ongoing study where women are enrolled in this trial, positive trial. We have not seen the results yet, but 500 patients, more than 500 patients who were allowed to stop the hormone treatment with tamoxifen, to stop it. After 2 years of tamoxifen, they were allowed to stop the tamoxifen and to try to get pregnant. This study wants to investigate whether there is a risk in stopping tamoxifen after 2 years in terms of recurrence. But as it sounds at the moment, it appears that when you are pregnant after breast cancer, the risk of recurrence and the risk of death is definitely not impacted by the pregnancy. Now, if we think about the options when you do not have stimulation of the ovaries available because there is no time, then the question that we have to ask is whether you can remove a complete ovary to have as many pieces of cortex as possible, or whether you have to restrict your procedure and you have to take just biopsies. Well, at the moment, the answer is still undecided. There is a risk, of course, of premature menopause if you remove too much of the ovary. So we have to think in terms of, is there a high risk of infertility because of the chemotherapy? Well, in that case, it is possible to remove a complete ovary. However, if you think that there is still a good chance that the woman will still have recovery of ovarian function, then it's probably better just to take biopsies in order to prevent premature menopause. IVM, in vitro maturation, it's an innovative and sometimes experimental approach. Usually when you are seeing women who are young, who have many follicles, like polycystic ovaries, then you can perform ovarian puncture, follicle puncture, and remove these eggs transvaginally to mature them. In the setting of ovarian tissue, you can cut the tissue, you can isolate immature eggs, and you can mature these eggs. So this is, I would say, for experienced labs who have good results with this, not for everyone. Now, in the women where we did IVM, we had on average 6.7 eggs collected, which is not bad. And those women who returned are still very, very little, very few. We had 5 women who returned after vitrification of eggs, after IVM. And of those, we had 1 baby. And women who had embryos vitrified after IVM, those patients, 7 women, returned with the desire of pregnancy. And in these women, we also have 2 live births with frozen material from IVM, which is promising. Now, ovarian tissue transplantation, as a final topic of this talk, is increasing in popularity. We know that these days more than 150 babies are born after transplantation. So you can either transplant the fragments in the peritoneal window, or you can transplant it on the heterotopic ovary. We have had 2, but this needs to be updated now, 3 live births in 6 women who have a desire of pregnancy. It's important to recommend that ovarian tissue transplantation has a risk of reintroducing malignant cells. I will tell you more about this in 2 minutes. Now, if you perform a transplantation of ovarian tissue, then there is a problem, because the follicles in the graft, when you transplant the graft, the follicles are activated as a process of hypoxia and the surgery. And this gives a burst, a very quick release of many follicles at the same time, which is an unwanted situation because you're losing these follicles. And the idea is in the future to add recombinant anti-Mullerian hormone during the tissue grafting in order to prevent this release of follicles. Now, reintroduction of malignant cells, yes, certainly in women with leukemia, it's very dangerous because leukemic patients, they have leukemic cells everywhere, also in the ovary. Usually it's safer to perform ovarian tissue cryopreservation after 1 or 2 rounds of chemotherapy, just to wash out the malignant cells from the ovary. And then in any case, before you transplant the ovarian tissue in a leukemic patient, it's important to do many tests, molecular tests, histology, to make sure, absolutely sure, that there are no leukemic cells left in the transplant, in the graft. The first live birth was published 2 years ago in a woman with leukemia who was in remission and who had her ovary transplanted back. Now, as a final word on long-acting GnRH agonists to protect the ovarian function has been recommended, certainly in women with breast cancer. So breast cancer patients should receive standard monthly injection of 3.75 milligrams of GnRH agonists in order to protect ovarian function. Whether this increases the chance of a live birth is still not known, but it protects to a certain extent against ovarian insufficiency. So in conclusion, we, and in fact, this is an evolution in many countries, we recommend that fertility preservation should be an integral part of oncology care. Timekeeping is important. If you have time to stimulate the ovaries, then do it, because ovarian stimulation with oocyte freezing is still considered as the standard best approach in the majority of cases. Thank you so much.
Thank you, Professor De Vos. Dr. Milicic?
Thank you, Professor De Vos, for a very interesting presentation and explaining us how important is the fertility preservation for all the patients. I can now give the audience to make some questions. Is there any questions?
Okay, there is one question from the audience and one question from Professor Timeva. The question from the audience is, Professor De Vos, to your knowledge, are there countries which pay for fertility preservation in cancer patients on a national level or through a specific fund, or it is mostly paid out of the pocket?
Well, in my understanding, and this is also looked at within the European Society, ESHRE, we see that almost half of the countries in Europe have a public, on a national level, a public reimbursement, public funding, which in Belgium was started 3 years ago in 2017. So all women who are younger than 37 can have ovarian stimulation with egg freezing or ovarian tissue freezing for free. And also in other countries, including in France, this is possible, in England. So many more countries are starting to offer this approach, because I agree that this is a very expensive situation for cancer patients who sometimes have to pay the cancer treatment themselves. And if they have to pay on top of that, they have to pay fertility preservation. This is very, very hard for many patients.
Professor Timeva wants to ask a question. Professor Timmer, could you turn on your...
Yes. Yes. Do you hear me?
I hear you.
Hello. Thank you for your interesting presentation. My question is concerning about using tamoxifen as a co-administration drug during control ovarian hyperstimulation in the patient with the breast cancer. Do you think, do you have any opinion how the tamoxifen influence the quality of oocyte if we use this drug as a co-administration during control ovarian hyperstimulation?
Mm-hmm. So your question is a very important one. Unfortunately, what we use here is not tamoxifen, but a different aromatase inhibitor, which is letrozole. With letrozole, we have seen that there is no negative impact on the cancer development. That's a very important one, and no impact apparently on the number of eggs that you can obtain. Some studies have shown that there is an impact, but other studies have not shown any impact from letrozole on the number of oocytes. With regard to the impact on the quality, according to the current studies, there is no negative impact from these co-treatment molecules on the quality of the oocyte. But the problem is with quality, it's the number of women who come back to use their eggs after this type of stimulation. This number is still very, very low. So it's very hard to compare the chances of pregnancy in women who had this co-treatment compared to those who did not have. But in general terms, I think it's at the moment, it's the best option to stimulate these women with breast cancer with co-treatment. You could use tamoxifen, you could use letrozole, and also we even give letrozole in women with estrogen negative tumors, because we believe that sometimes in some parts of the tumor you may find estrogen positive receptors, estrogen receptor positive cells. So it's probably safe just to do it like that.
Yes, thank you very much. Thank you.
You're welcome.
Thank you, Professor De Vos. There are no other questions written from the audience. If there are any questions, you could raise your hand to the software, of course.
Yes, I have one, only quick one. If there is contraindication for stimulation and the woman desire to have freezing the oocyte, what to do to postpone the treatment and to collect the oocytes in several natural cycles, or to do the treatment without egg freezing?
Well, natural cycle treatment in the setting of fertility preservation is probably not the best idea, because you would like to have as many eggs as possible to cryopreserve. So this is not what we recommend, and the guidelines do not recommend natural cycle IVF for fertility preservation. If women do not want to have ovarian stimulation because they're afraid of ovarian stimulation, this is perfectly understandable. We should really accept the wish of the patient. We should not force the patients to something that they don't want. We have to accept this. We have to say, look, if you don't want stimulation, that's fine, but then the only option is to preserve the tissue, to perform a laparoscopy and to take biopsies. This is the only. If she doesn't want that, then yeah, there is nothing you can do.
Thank you very much.
You're
so
welcome.
To preserve the tissue. Thank you.
Well, or do IVM, but this is very experimental in many labs.
Thank you, Professor De Vos.